So what are the different types of meniscus tears, and do they all need surgery? I'm Dr. John Tait. I'm a non-surgical orthopedic regenerative medicine doctor, and I'm going to walk you through that today because there are a lot of different tears when it comes to the meniscus. In a prior video that you can find on the channel here, I talked about what is a meniscus, what does it do, and how does it commonly get injured. So let's just start there really quick. So the meniscus, if I pick up one of my handy dandy models here, and we look inside a knee joint, it is this white structure here. So sitting between the bones, the blue is the hard cartilage on the end of the bone that we absolutely want to preserve at all costs. When that dwindles down, people get knee replacement. The flexible cartilage, this white structure you see sandwiched between here, the filling in the Oreo cookie of the knee, that is a meniscus. And this is a flexible piece of cartilage. And just what I was doing there with my hands, this is what happens. When we flex the knee, the bones track over that meniscus, they do compress it, and certainly if you squat down, some people can injure these doing really deep, heavy squats because they pinch down on the back of that meniscus and they tear it. More commonly what we see is people have a rotational injury. So when they step, plant, twist, they can tear that meniscus. So multi-directional sports, more commonly we see these people pivoting, tennis players, pickleball players running around a court, stop, start, pivot. Same thing with golf. If you're locked in, posting up, rotating on a knee, that's a good mechanism to tear meniscus, especially in a middle-aged, older crowd where that tissue becomes less flexible like a lot of our body. But today what we want to dig into is when you do tear the meniscus, what are the different types of tears? What tears can be treated effectively without surgery and which tears go to surgery? So going through these in order, I'm going to take my destroyed model over here so we can look inside of it top down. So when we're looking at that meniscus, it looks like a C on both sides here. So there's a medial, which is on the inside of your knee as you look down at it. There's a lateral meniscus as you look down at your knee to the outside of it. The tears are usually named for the direction that they're going through that tissue. So if we look at a radial tear is going to start on the inside and radiate out through that. Okay, that's first tear. Longitudinal is going to run kind of along the edge of that, but in a longer, so it's bending around that C shape. So we call it a anterior horn, a posterior horn, and the middle section of that meniscus is called the body. So those longitudinal tears tend to run through a longer stretch of that. Some can be isolated to just a portion like the anterior or posterior. Some run the length of it. Again, they're not as clean in life as we see in textbooks, but when you're reading your own MRI reports and they talk about a radial tear that's radiating out, longitudinal running along this, and horizontal tear is kind of a version of a longitudinal tear, but we usually see that more on the inside and periphery of the meniscus tissue. Okay, the next one, or the next cluster, are the ones that are typically more problematic. So we're going to recap this and then go back to what is the actual treatment for those. The next cluster of meniscus injuries tend to be more significant ones. These are called flap tears. So if we take that C shape, all right, and we stack a couple C's on top of one another, and we tear a portion of that into a flap, now we have something that looks like this. And this is my poor hand model depiction of a bucket. So if this is the bucket and this is the handle on top of the bucket, if you see that in your MRI report and they say bucket handle tear, those are the ones that we don't like to see. Because that bucket handle means there's a flap of this meniscus now that's kind of attached. It's anchored on both ends, but it's flapping up kind of free into the joint. So if we go back to this intact model and I'm flexing this knee over the top of that, and there's a flap of cartilage inside there that is moving from that meniscus, it can get caught inside that knee mechanism. So the symptoms we typically see in patients that have that type of tear is they're going to get a catching sensation, even a locking sensation, where if you flex your knee and you go over the top of that bucket handle tear, and now you're trying to release the knee back into extension, some people literally can't do it unless they maneuver out of it and unlock their knee. So locking meniscus is a challenge for sure for a non-surgical doc like myself. The final one in that cluster of flap tears, so we have, again, the bucket handle, and then we have something that they like to call parrot beak because it just looks like a parrot beak. So on the inside of this meniscus, again, as it's thicker on the edge, and then it thins down as it comes to the inside of the joint there where we where we contact a lot of load and put the bones together there. But on that inside, instead of being anchored on both ends and flapping up like a bucket handle, it just means it's free floating off of one side. So it can tear on either side, and there's a flap torn out, and it's triangular, so somebody at some point called it a parrot beak because it looks like a parrot beak. Those also can be problematic for the same reasons. So to recap, a bunch of different types of meniscus tears, okay? Radial, horizontal, longitudinal, bucket handle, and parrot, kind of the big cluster categories. But it's never that simple. And in reality, people can have what's called a complex tear, which means they can have a combination of 1 or 2 or even 3 tear types in that tissue. So, again, as you're deciphering your MRI, if it wasn't explained well to you, hopefully this is helping you read Google or YouTube as you're doing now to try to figure out what type of tear that is. The final group, so if we tackled all those, I'm going to talk about now what we say are root tears. So if we look at the meniscus side profile on this model that I've conveniently torn in half, the root of the meniscus on the back side and the front side, this is where this tissue is rooted down to the bone. That's why we call it a root. Root tears are also very tough to treat, very problematic for a couple of reasons, because a root literally anchors something. And when the root tears in the meniscus is no longer firmly attached to the bone underneath it, which allows it to slip and slide. Okay, so this is what we call an extrusion of the meniscus, where if we look at the alignment of this model, we see that meniscus is contained in line with the bone. And when we have a root tear, it allows that meniscus to kind of drift out. We call it an extrusion. They're graded for how far is that meniscus drifting off what we call the tibial plateau here. Same rules apply with those, similar to bucket handle tears, in that they can get caught in the mechanism of the knee, and those can be very problematic for people that are highly active, on the knee, rotating, flexing the knee, not just sitting at a table playing checkers. So these slide around in there, and that can be a really tough thing to do, or a tough thing to treat. So let's get into the treatment. So what are those types of tears do I handle in my practice very successfully with non-surgical tools? So from the 1990s forward, we've been using things in non-surgical orthopedics, primarily platelet therapies, stem cell therapies. This is where we can take cells from you and we can inject it into that tissue to stimulate healing. So say you've given this time, you've given it space to heal, you've given it the old conventional RICE method, which is rest, ice, compression, and elevate. And now 6 to 8 weeks have gone by. You don't have catching and locking in the knee. So maybe you saw an orthopedic surgeon and they said, man, we're not crazy about scoping this. Why? Because in the old school, which is say 1980s, 1990s, more knees got scoped in that time because, hey, the arthroscope was just an amazing invention where you no longer had to open somebody's knee up to look inside of it. You could poke a hole in it, stick a camera in it, poke another hole in it, stick a tool in there, and you could go in and repair a meniscus or shave down those flap tears. So it was really quite an amazing invention in orthopedics, and really evolved orthopedics now, where so many surgeries are done through a scope instead of open. But what they found is when we would go in there, I say orthopedic people like me, surgeons would go in there and they would shave that meniscus down. What they saw is they would give people short-term relief. It certainly helped their pain, but when we fast forward about 6 months, a lot of those patients weren't a whole lot better. And the caveat to that, what we also saw is when we take away the meniscus, when we shave down part of it, and the meniscus is designed to carry and displace the force across the whole entirety of the articular cartilage, that hard cap of cartilage on the end of the bone, then what we saw is people were developing what we call post-traumatic arthritis from the injury itself, and also the surgery as kind of a second trauma to the knee. So we don't want to shave away the meniscus unless we really have to. So a lot of times with these other types of tears, like root tears and extrusions like that, a lot of docs now are really trying to reconstruct that attachment, go in there and repair that meniscus and tack it back down if we can. If the meniscus is intact and just sliding, and those can be repaired, and you're a highly active person, then you probably want to have that done. If it's a big flap tear, okay, that again is a problematic category of tear because of that catching, locking mechanism in the knee. So oftentimes those will go to arthroscopy in an attempt to tack that flap down and repair it if possible, or the second best option there is to shave down a minimal amount of the meniscus, what we call a meniscectomy. But again, all surgeons that do this are going to go in there and be as sparing as possible. In the old days, they just take the whole meniscus and throw it over their shoulder in the OR. In the new days, we're trying to really spare that meniscus tissue, because the more of it you take away, the more force concentration you get on the cartilage, and then you start to wear that knee out even faster, sending people kind of down the hill towards the, quote, inevitable knee replacement. So we call it now meniscus preservation surgery. Some of the cool things that are coming in the future may be, and they're already using some of these, which are meniscal transplant tissues. Orthobiologics combined with that. When I say orthobiologics, we're over here to platelets and stem cells and things like that. So for the category of meniscus that isn't extruding and shifting around, say that's intact, or the non-flap tear meniscus that's not mechanically binding your knee, the best things we have now in non-surgical orthopedics are what we call orthobiologic cellular treatments. So platelets and stem cells, because if we can get in there with healing growth factors, which is what we're getting from those cells, if we can go deposit them into that meniscus, seed them in there with just a needle. Okay, I know people aren't fond of needles, and I say just a needle, but if it's just a needle and not a surgery, it's even less invasive than the arthroscopy. So if I can look into where that tear is and place those growth factors in proximity to that tear, and then we choreograph 6 to 8 weeks of time for healing, appropriate rehab, and yes, time away from activity, then a lot of those tears can heal really nice. So if you have that category of radial, longitudinal, horizontal, and peripheral tears without mechanical symptoms, then you should absolutely be looking at some form of orthobiologic treatment for your meniscus tear. So I hope that helped you today, give some clarity to a confusing topic that I get a lot, because I see meniscus injuries a lot in my practice, and a lot of people assume they all go to surgery, and they don't need to. So if you like the content, go ahead and click that old like button. If you want more content like this and want to get updated when we put new content out, subscribe to the channel. And if there's any comments on this that were not clear today, drop them below, and we'll do our best to walk back through those and answer your questions. Hey, and if we can help you in any way from a non-surgical orthopedic perspective, check out the notes below the video. There's a link in there that takes you over to a discovery page, or you can talk to one of my happy, smiling team members who can review your case and see if there's something that we do that we can help you non-surgically, because that is what we do here at ORIGEN.